Hello everyone. Am I audible to all of you? Just send a message or raise your hand on the chat so I know I'm audible. All right, that's great. Okay, so hello everybody. I am Dr. Pradnya, and me and the entire team of Med Exam Expert welcome you to this free webinar on the multiple pregnancy. So I would just like to take this opportunity and say a huge thank you to Med Exam Expert, one for clearing my, helping me clear the most difficult exam that I ever thought I would be giving. And second, for letting me do this, in whatever little way that I could help somebody, I would be really grateful. So I'm really thankful to Med Exam for giving me this opportunity. So let's get started without any delay. Today's topic is multiple pregnancy. Let me just tell you how we are going to go about this. And so the sources for today's discussion is the NICE guideline 137, which was published in 2019, and the Green Top guideline, which is the management of monochorionic twin pregnancy. And this was published in November 2016. So I will initially be giving you all 4 questions. I will be reading them out. You can take down the answers on your notebooks or whatever. And after the end of the discussion, we will be discussing the answers. This is so that 1, you get an idea how the questions come. 2, we can actually understand how to read a particular guideline and how to modify it, so we know what kind of questions come and how to answer them. And 3, to see if you're actually paying attention during the session. All right, so let's begin. Here is the first question. A pregnant woman has just had her 12-week scan. She is diagnosed with a dichorionic diamniotic twin pregnancy. She queries the chance of having them prematurely. What proportion of all twins deliver before 37 weeks? 25%, 30%, 40%, 50%, or 60%? Okay, this is the first question. I'm moving on to the second question. A 34-year-old primigravida attends for a first trimester ultrasound scanning at 12 weeks. This is a spontaneously conceived pregnancy, and she is found to have a monochorionic diamniotic twin pregnancy. Dating of the pregnancy should be based on what? The crown rump length of the smaller twin, the crown rump length of the bigger twin, the mean crown rump length of both the twins, the mean sac diameter of the larger twin, or the mean sac diameter of both the sacs. Okay, that was the second question. I hope you all are taking down the answers. All right, now coming to my third question. Ultrasound is routinely used for assessment of fetal well-being in women with multiple pregnancies. Which one of the following statements is correct regarding the use of ultrasound scan in fetal assessment? First option is detailed anomaly scan of twin pregnancy should take place between weeks 20 and 22. Fetal ultrasound assessment should take place every 3 to 4 weeks in uncomplicated monochorionic pregnancy from 16 weeks of gestation onwards until delivery. In twin pregnancies showing selective growth restriction, surveillance of fetal growth should be undertaken at least every 3 to 4 weeks with Doppler. First trimester nuchal translucency measurements should not be used to screen for twin-to-twin transfusion syndrome in monochorionic pregnancies. And the last option is women carrying twins should be offered nuchal translucency measurements between 11 weeks to 14.1 weeks of gestation. This is the last question. A 34-year-old had a booking scan at 12 weeks and it shows a twin pregnancy with T sign. CRL at this gestation was equal to 12.5 of both the twins. What would you document her plan of care? So we aim for delivery at 36 to 37 weeks, cesarean section recommended mode of delivery, serial scan every 4 weeks, and quad test screening at 16 weeks. So I hope you all have taken down the answers to the questions that I shared. I would just like to tell all of you all if I'm not making sense or if I'm unclear or if you have any doubts, you can stop me whenever you all want, and I will repeat it till you guys understand. All right. So let's start with the multiple pregnancy NICE guideline. We will be discussing them under the following agenda. We'll be talking about the ultrasound features, screening for chromosomal abnormalities. Then we'll talk about when to refer these twins to fetal medicine unit. Then we'll look at the antenatal care, maternal complications, fetal complications, when to deliver them, how to deliver them, and what finally is the postpartum care. So now coming to the ultrasound. The first trimester ultrasound scan is usually done between 11 to 13.6 weeks of gestation, and the CRL at this gestation is usually 45 to 84 millimeters. So it is very important to remember these particular the weeks and the CRL, because they do ask these things. They do ask these things in the SBAs, and it's important to remember. So what we look at in the first trimester ultrasound scan is we look at the Corionicity and the amnioticity, and I'll be talking about this in detail in the next slide. We want to look at the gestation age, and this we want to do from the biggest baby. That is, because we don't want to estimate it from the baby with an early growth pathology. So we always choose the largest baby to assign the gestational age for a twin pregnancy. Then this scan is also used for screening for chromosomal anomalies to look at fetal viabilities. A transabdominal scan is usually done. If the transabdominal scan is inadequate, we would do a transvaginal scan. If that is still inadequate, we will refer the patient to a senior consultant. We are never going to do a 3D ultrasound to diagnose Corionicity. Okay. Sharika is asking me how many hours is the session for. Let's see, Sharika, maybe around an hour or something. Okay, so moving on. Yeah. So how do we look at the how do we look at the Corionicity? We look at the Corionicity with the number of placental masses. One thing, if there are two placental masses, it is a dichorionic pregnancy, and if there is one placental mass, it is a monochorionic pregnancy, right? Presence of amniotic membrane and the membrane thickness. If there is a membrane present, it can either be a dichorionic diamniotic or a monochorionic diamniotic pregnancy, right? And the famous lambda sign and the T sign. So lambda sign usually talks about the insertion of the membrane into the placenta, right? That looks like a lambda, and that is seen in DCDA. It is thicker, okay? And T sign is seen in monochorionic diamniotic pregnancies. If the presentation is after 14 weeks, we can also use discordant sex to know about the Corionicity. In this sense, if it is a boy and a girl, we obviously know it is a dichorionic diamniotic pregnancy. Right? The highest specificity and sensitivity of diagnosing Corionicity is before 14 weeks of gestation. All right. So that is why whenever you are uncertain about the Corionicity, what you do is you take a photographic evidence, you keep it, you show it to your senior. If it is still uncertain, what you do is you refer to fetal medicine unit, and that has to be done within 14 weeks. And if the diagnosis is still uncertain, you manage the pregnancy as a monochorionic pregnancy. And this is a very popular SBA that comes in exams. All right, so this is just a picture showing dichorionic pregnancy. This is the lambda sign, right? And this is the T sign. So how my mentor made me remember this was T means trouble. And we all know how much trouble monochorionic pregnancy causes. So T sign is for monochorionic pregnancy. I hope that makes sense. Okay, so moving on to the next slide. Yeah, now coming to the screening for chromosomal conditions. How do we screen for chromosomal condition in twins? When it comes to twins, we do the same thing that we would do for a singleton pregnancy in the first trimester. That is, we would do a first trimester combined screening test. In this, we would consider the maternal age, the NT, and the maternal biochemistry, right? And it is seen that there is an increased risk of Downs in dichorionic twins and triplets as compared to singleton. Also, there is a lesser incidence of Downs in monochorionic pregnancies as compared to singleton pregnancies. When it comes to reporting the particular chance of having a Downs or any chromosomal anomaly in a dichorionic, it would be according to each fetus. That is because each fetus carries different genetic material, whereas in a monochorionic pregnancy, either both the fetuses are affected or they are unaffected. So the chance will be reported as a single pregnancy chance. I hope I'm making sense. Dichorionic pregnancy is for each fetus. Monochorionic pregnancy is for the entire pregnancy. All right. Now talking about a little more about screening for chromosomal conditions. When we are screening for twins, the false positive rate is twice that of singleton pregnancy, that is 10%. So first trimester combined screening has a false positive rate of 5% in singleton pregnancies, whereas it has a false positive rate of 10% in twins. Twins and triplets also have a greater likelihood of being offered invasive testing. They also have a greater likelihood of having complications due to these invasive testings. And sometimes women miss the opportunity to have the first trimester screening. So what they do is they are referred, when they come in the second trimester, they are offered a quadruple test. But as we all know, the sensitivity of quadruple tests is not as high as a first trimester combined screening test. The next screening that we would do is at 18 to 20.6 weeks of gestation. It is important to remember these weeks. At this gestation, we will want to look at the structural abnormalities in twins, as it is pretty well known that twins are at an increased risk of structural abnormalities, especially cardiac and neural tube defects. Okay, so how do we do screening in triplets? So in triplets, we are not allowed to use the biochemical markers, maternal biochemical markers. So how we screen them? We take the NT and we take the maternal age for screening. All right. And in both these cases, if the risks exceed 1 out of 150, if the risk is more than this, we refer them to fetal medicine unit. Right. I hope I'm clear. If there are any doubts, just please stop me whenever you have a doubt, and then we'll talk more about it. Okay. Now, these are a few indications for referral to the fetal medicine unit. In cases of twin-to-twin transfusion syndrome, we'll be talking about this in detail in the GTG. Twin reverse arterial perfusion sequence, or TRAP, conjoined twins, suspected TAPs, single fetal demise, all monochorionic monoamniotic twins, and twins with single fetal anomalies or both the fetal anomalies. We will also want to refer pregnancies that are complicated by a fetal weight discordance of more than 25%. This is important to remember. And if the estimated fetal weight of any one of the twin is less than 10 centile for that particular gestation, even these twins we will want to refer to fetal medicine unit. Now coming to the antenatal care. The antenatal care will be under a multidisciplinary team. So this team will comprise of a consultant obstetrician, a specialist midwife, a sonographer. Sometimes we would have to involve the fetal medicine unit. A lot of times we will have to, later on in the pregnancy, have to involve the anesthetists and also the neonatologists. So number of ANC visits is different for different type of twins. And I mentioned them here. You can take a look. Dichorionic diamniotic, it is 8. For monochorionic diamniotic, it is 11. For triamniotic triplet, it is 9. And for dichorionic triamniotic or monochorionic triamniotic triplet, it is 11. And like I already told you, triplet or twin with a shared amnion has to be a consultant in a tertiary level fetal medicine center. Now coming to the antenatal care that we offer to twins and triplets, you have to give them the same advice about diet, nutrition, and lifestyle as you would give to a singleton pregnancy. It's not like because they're carrying 2 babies, they're supposed to eat twice the amount of food or something like that. They have to take the same diet and same nutrition. Also, there is a higher incidence of anemia seen in twins. Therefore, we perform an extra fetal blood count, extra FBC at 20 to 24 weeks, in addition to the routine screening. Um, all right. I'm going fast. Fine. I'll slow down. So twins have a higher incidence of anemia. Therefore, we do a FBC at 20 to 24 weeks, in addition to the routine screening that we do at 28 weeks of gestation. All right. So now let's move on to the maternal complications. So one of the known maternal complications is hypertension. What we do to prevent hypertension is we check BP at every visit, and we test urine for proteinuria at each appointment. And if these women have another high risk factor, like if they are primary, if they are more than 40 years of age, if the pregnancy interval is more than 10 years, if the BMI is more than 30, or if there is a family history of preeclampsia. Can you repeat the previous slide about ANC with it? 1 second. Yeah. So if any of these risk factors are present, we would want to start them on aspirin to prevent prevent them from having hypertension. Yeah. This is the slide you wanted to see. Jijisha, you wanted to see the slide? You wanted to see the slide about ANC visit. Okay, just a second. Let me go back. This slide?
Yes.
Yeah. You can take it down. Let me know when you're done.
Done.
Yeah. Okay, so let's move on. Yeah. So now let's come to the fetal complications. We all know that twins and triplets famously have preterm deliveries. The incidence of preterm delivery in twins is as high as 60 in 100 twin pregnancies, and this happens before 37 weeks of gestation. And in triplet pregnancy, it is 75 in 100, and this happens before 35 weeks of gestation. All right, these incidences are very important. They come as SBAs as well as EMQs. But what we can't do is we cannot screen for preterm birth with the help of fetal fibronectin and with the help of home uterine activity monitoring. So screening is not going to work, right? And we can't even offer any of these interventions to prevent spontaneous preterm birth from happening, like intramuscular progesterones or aberrant pessaries or bed rest, cervical cerclage, oral tocolysis. None of these are allowed to prevent preterm birth from happening. All right. Another complication that twins have is they have fetal growth restriction. And how do we prevent this or pick it up early is, after 24 weeks, we start monitoring for fetal weight discordance using 2 or more biometric parameters like estimated fetal weight or abdominal circumference. Also, we measure the amniotic fluid levels with the help of deepest vertical pocket. The formula for measuring estimated fetal weight discordances, we take the fetal weight of the larger twin, subtracted from the smaller twin and divided it with the larger twin. Whenever discordance is more than 20%, or if one of the twin has a birth rate of less than 10 centile, we increase the diagnostic monitoring to weekly. And when this crosses to 25%, and when one of the babies is again less than 10 centile, we refer them to tertiary fetal medicine center, like I have already previously told. We have to keep monitoring these babies for fetal weight discordance. And these are lines from NICE. The interval should not exceed 28 days for women with a dichorionic twin pregnancy and 14 days for women with a trichorionic triplet pregnancy, right? I've just summarized all the gestational age and the time of delivery for them. You can take this down. Let me know when you guys done. So I will move on. Monochorionic monoamniotic twins have to be delivered by 32 to 34 weeks. Dichorionic diamniotic twins have to be delivered by 37 weeks. Monochorionic uncomplicated twins can be delivered by 36 weeks. Triplets have to be delivered by 35 weeks. Monochorionic twins who have been treated for twin-to-twin transfusion syndrome have to be delivered by 34 to 36.6 weeks. Monochorionic twins complicated with type 1 selective growth restriction have to be delivered by 34 to 36 weeks. And type 2 and 3 have to be delivered by 32 weeks. All right. Yeah, so I hope this is done. So I can move on to the next slide. Right. So now we spoke about the gestational age gestational age when we'll deliver. So now let's move on to how we want to deliver these babies. So vaginal delivery is allowed for dichorionic diamniotic and monochorionic diamniotic twins, unless and until the first baby is cephalic. It is an uncomplicated pregnancy. The twins are more than 32 weeks of gestation, and there is no other obstetric contraindication to labor, and there is no fetal size discordance. All right, but we would consider a cesarean section if the first twin is not cephalic. If the twin is an established preterm labor between 22 and 32 weeks, if it is a monochorionic monoamniotic twin, and when do we deliver these twins? At 32 weeks, right? Like we already saw, at 32 weeks. Okay, and a triplet pregnancy also has to be delivered by a cesarean section. Now these are some lines that can come as EMQs. They will twist these lines and give you so as to pick the exact right line or something like that. So these are important. It'll be great if you could learn these particular lines. Like more than 1/3 of women who plan a vaginal birth go on to have a cesarean section. Almost all women who plan a cesarean section do have one, but just a few have a vaginal birth before the cesarean section can be carried out. And a small number of women who plan a vaginal birth will need an emergency cesarean section to deliver the second twin after vaginal birth of the first twin. Previous slide, Reena. All right, 1 second. This one? This one, Reena? Let me know when you're done, please. All right. Okay, let's move on. Yeah, now coming to the intrapartum management of twins. Twins always, a continuous CTG has to be done. The babies have to be continuously monitored throughout pregnancy. We use a dual channel cardiotocograph monitor for these twins. If there is a CTG abnormality, a senior has to be involved and an individualized decision has to be taken. A portable ultrasound is used to diagnose the position of the first twin, so we can take a decision whether we want to undertake a normal delivery or a cesarean section. And whenever the CTG is pathological, we have to deliver the baby within 20 minutes. If vaginal delivery is not possible, a cesarean section has to be carried out, right? And after birth of the first baby, we continue to monitor the second one using the CTG. And if it is suspicious or pathological, and we know that the vaginal delivery cannot be achieved in 20 minutes, in certain situations, we would have to consider a cesarean section for the second twin, even after vaginal delivery of the first twin. This happens in rare conditions, and this is a valid indication for a cesarean section. Fetal scalp stimulation is not to be performed in twins, and after birth of both the babies, consider double clamping the cord to allow for umbilical cord blood gases to be sampled. Okay, now moving on to the postpartum management. Multiple pregnancy, as we all know, is a risk factor for increased blood loss at delivery. because of overdistension. Previous slide. Right, 1 second. This one? This one, Sharika? Previous one? This one? Let me know when you're done, please. Yeah, all right. So coming to the postpartum management, like we all know, multiple pregnancy is a risk factor for increased blood loss. So what do we do? We do active management of the third stage. Mushrafa, please turn off your mic. Mushrafa, please turn off your mic. Backing team, please mute Mushrafa. Right, done. Yeah. So let's move on to now the next guideline, that is the GTG on monochorionic twin pregnancies. So there are specific complications that are specific to monochorionic pregnancies, like the twin-to-twin transfusion syndrome, the twin anemia polycythemia sequence, twin reversed arterial perfusion sequence, selective growth restriction, and single fetal demise. So now let's move on to twin-to-twin transfusion syndrome. It is associated with 15% of monochorionic twin pregnancies. Okay, and we use the Quintero system to classify twin-to-twin transfusion syndrome. This basically happens because the placenta is shared between both the twins and they are separated by a membrane. So there are anastomosis which allows blood to flow back and forth between the twins, and any imbalance in this leads to twin-to-twin transfusion syndrome, right? So there are 5 gradings. Okay, in the first one, how I used to remember is it, in the first one, we look at the amniotic fluid. In the second one, we look at the bladder. In the third one, we look at the Doppler. In the fourth one, we look at ascites, pericardial or pleural effusion. And in the fifth one, we look at death. So in the first one, this is when there is oligohydramnios in one and polyhydramnios in the other one. So oligo when the DVP is less than 2, and poly when the DVP is more than 8, when we are seeing at twins before when the gestation is less than 20 weeks, and when the gestation is more than 20 weeks, the DVP has to be more than 10, right? But donor bladder is visible in this one and the Doppler is normal. Coming to the next stage, bladder of the donor twin will not be visible, right? And there will be severe oligohydramnios due to anuria in the donor, right? In the third one, the Doppler will be critically abnormal in either the donor or the recipient with typical abnormal umbilical artery Doppler velocities, okay? And in the fourth one, there will be ascites, pericardial effusion or pleural effusion, scalp edema or overt hydrops. This will usually be present in the recipient. And in the fifth one or both of the babies would have died. I hope I am making this clear. This is a very important classification system and you have to know this by heart. If any of you all want me to repeat it or want me to stay on the slide for longer, just let me know. All right, so I will move on to the next one. That's great. So now coming to twin anemia polycythemia sequence. This is pretty much like twin-to-twin transfusion syndrome, but the only difference is the oligopoly sequence that happens in twin-to-twin transfusion syndrome will not happen here. Okay, and this is normally not seen in all. It is not as common as twin-to-twin transfusion syndrome in monochorionic pregnancy, as it is seen hardly in 2% of uncomplicated monochorionic amniotic pregnancies. But the incidence increases after a twin-to-twin transfusion syndrome has been treated. Okay, so it is seen in 13% of monochorionic twin pregnancies post laser ablation, right? So these are the babies that we want to monitor for TAPS. And what we see is, we will see signs of fetal anemia in the donor and polycythemia in the recipient. without any significant oligopolysequence that is seen in twin-to-twin transfusion syndrome. So how exactly is it seen? The MCA PSV of the donor will be more than 1.5 multiples of normal median, right? Because the baby is anemic. And as the recipient is polycythemic, the MCA PSV will be less than 1 MOM. I hope I'm making this clear. Just note this down. This is very important. Okay. Now moving on to selective growth restriction. This again is seen in 10 to 15% of monochorionic twin pregnancies. And this is defined as a growth discordance of more than 20%. We have already talked about how we calculate growth discordance. Selective growth restriction is usually because of unusual placenta sharing, or if there is a velamentous cord insertion, so that particular twin gets lesser nutrition as compared to the other twin. Okay, this again is graded in grade 1, grade 2, and grade 3. In grade 1, there will be growth discordance, but when you do the Doppler, there will be a positive diastolic. Guys, some baby wants to learn part 2, is it? Please put off your mics, guys. Whose mic is on? Samara. All right. Yeah. So where were we? Yeah, selective growth restriction. Grade 2 will be when there is growth discordance with absent or reversed end diastolic velocities in one or both the fetuses. And grade 3 will be when there is growth discordance along with cyclical umbilical artery diastolic waveform. Okay. So now moving on to the outcome of monochorionic twin pregnancies. Monochorionic twins are high risk and they do have a higher fetal loss rate, especially in the second trimester. They are associated with a higher risk of neurodevelopmental morbidity. And when you try to do screening for any chromosomal anomalies using NIPT, the detection rate is 94.4% and the false positive rate is almost 0%. Right? And we do have to monitor these pregnancies as they are high risk. And how do we monitor this? We monitor every 2 weeks in uncomplicated monochorionic pregnancies from 16 weeks onwards. So every 16 weeks, we will be monitoring them every 2 weeks until delivery. And what do we look for in these scans? We look for fetal biometry. We look for the amniotic fluid. We look for umbilical artery pulsatility and the fetal bladders. All right. Now coming to screening for twin-to-twin transfusion syndrome. Never use the NT scan to screen for twin-to-twin transfusion syndrome. Okay. And we do USG every 2 weekly from 16 weeks onwards. And whenever you always tell the patient that whenever you feel any increase in your abdominal size, or if you have any sort of breathlessness, just immediately come to the hospital. Okay, and screening for twin anemia polycythemia sequence, like I already told you, it is seen following a fetoscopic laser ablation, which is done for twin-to-twin transfusion syndrome. So we will be screening only in these particular conditions. I hope I'm making sense. We will screen for twin-to-twin transfusion syndrome in all monochorionic pregnancies, but not for TAPS. TAPS we will screen only in babies who have undergone fetoscopic laser ablation and the ones complicated by selective growth restriction. And we will do this by MCA PSV, like how we screen for anemia in the same way. Now screening for selective growth restriction in twins. Abdominal palpation is not reliable when it comes to measuring the symphysiofundal height. All right. So we will start monitoring for selective growth restriction from 20 weeks onwards. Unlike twins, unlike TTTS, that is 16 weeks, and this is 20 weeks, and we do it every 2 weekly. And we will calculate estimated fetal weight discordance. Okay. So how do we treat twin-to-twin transfusion syndrome? These complicated cases always have to be dealt with in conjugation with fetal medicine center, right? And if they are presenting before 20 weeks, We use a fetoscopic laser ablation, and the procedure or the technique is known as Solomon technique. Following the laser ablation, we would want to monitor these babies weekly for the first 2 weeks and then every 2 weekly. And we will look at the estimated fetal weight along with umbilical artery pulsatility index, the MCA-PSV, and ductus venosus Doppler to monitor. When the patient is presenting late to you, or if the expertise are not available, or if the patient has to be transferred to a center where the expertise are available, what we do is amnio reduction, but always fetoscopic laser ablation is preferred over amnio reduction, right? And treatment for SGR, this again has to be managed in conjugation with fetal medicine unit. If it has occurred very early in the pregnancy and you know that the pregnancy is not going to continue, we individualize the management and do a selective reduction. Okay. And I've already told about the type 1, type 2 and 3 delivery. When is it done? All right. And if there is any abnormal ductus venosus Doppler or any computerized CTG short-term variation, we would want to deliver the babies immediately unless they are viable. And now coming to treatment for twin anemia polycythemia sequence, there is no proper management for this, but depending on the particular or individual case, we could either do an expectant management. If the baby is capable of surviving, we could deliver the baby. An IUT or intrauterine blood transfusion could be considered, or selective feticide or fetoscopic laser ablation. It is still not clear from the literature, and that is what the GTG says. Okay. Single fetal demise is again a very famous question, and the college loves this particular topic. This first line has come in the exam a lot of times, and after a single fetal death in a monochorionic pregnancy, what is the risk to the surviving twin of 1, death, and 2, of neurological abnormality? The risk of death is 15% and the risk of neurological abnormality is 26%. Okay, you all have to remember this no matter what. Even if you are woken up from sleep, you're supposed to remember this. Okay, and whenever this happens, these babies are referred to fetal medicine center. What you would want to do in such a situation is a fetal MRI brain 4 weeks after the quoted demise to look for any neurological abnormality. A lot of times question comes asking you, should you deliver when there is a single fetal demise? No, the answer is fetal MRI brain. Okay, and fetal anemia has to be assessed by MCA-PSV. Okay, so just because you all have been so patient, and I have just got a gift for you all. I have compiled all the important incidences from the entire guideline, the NICE guideline and GTG. You could take this down, and we would do that in the session as well. So these incidences are very important and have been asked multiple times in the exam. So you could take them down and let me know when you're done so I can move on. Right, so shall I move on or? Okay, great. So now coming to the questions, I would want to volunteer from one of you all, whoever has, you know, um, one second. Yeah. So yeah, I would want to volunteer from you all, whoever has written down the answer. Who wants to volunteer? I'm seeing a lot of new names here. Sharika, you want to answer?
Hello,
Hello.
can I share, ma'am?
Sure, sure. Who is this?
I am Shafia.
Okay. Hi, Shafia. So what do you think is the answer?
I will read the question or
Okay.
answer only.
Right. Oh, go ahead. Read the question.
Okay. A pregnant woman has just had her 12 weeks scan. She is diagnosed with a dichorionic diamniotic twin pregnancy. She queries the chance of having them prematurity. What proportion of all twins deliver before 37 weeks? Before 37 weeks, most of the twin go to labor in 60% cases.
Absolutely correct. That was great. So 60% is the answer. That was very nice attempt. So shall we move on to the next question? Who wants to volunteer for this one? Is there somebody else who wants to do it, or Shafia, you want to do this one as well?
Sure, ma'am.
Sorry?
I will continue.
Uh, let me just see if anybody else wants to attempt or... Okay, Shafia, go ahead.
Yes, a 34 years old primary gravida attend for first trimester ultrasound scanning at 12 weeks of gestation in a spontaneously conceived pregnancy. She is found to have a monochorionic diamniotic twin pregnancy. Dating of the pregnancy should be based on it. In twin pregnancy, we always choose the bigger one. So crown rump length of the bigger twin, B.
That's correct. Good attempt, Shafia. Shall we move on to the next question? Is there somebody else, or Shafia wants to continue doing it? Anybody else wants to attempt? Let me see. Jessica, do you want to attend? How about Manikam? All right, you go ahead, Shafia.
Ultrasound is routinely used for the assessment of fetal well-being in
Okay.
multiple pregnancies. Which one of the following statements is correct regarding the use of ultrasound scan in fetal assessment? Detailed anomaly scan of twin pregnancies should take place between weeks 20 and 22. True, ma'am. Fetal ultrasound assessment should take place every 3 to 4 weeks in uncomplicated monochorionic pregnancies from 16 weeks. Every 2 weeks, ma'am. Is a monochorionic, they haven't mentioned whether it is a diamniotic or not. So I'm not sure. But for yes, ma'am. The C. In twin pregnancies showing selective growth restriction, surveillance of fetal growth should be undertaken at least 3 to 4 weeks with the fetal Doppler ultrasound. This also I'm not sure, ma'am. The first trimester NT measurements should not be used to screen for twin-to-twin transfusion syndrome. Yes, ma'am, true. Should not be used. The
Correct.
women carrying twins should be offered NT measurements between 13 and 11 weeks plus 0 and 13 plus 6, ma'am. 6 days of gestation. Not 14 weeks plus 1. Okay,
correct. So what is
you,
your answer? What is the option?
First one, ma'am, A. That is the true.
First
A.
one, or think
detailed
again.
Anomaly. Detailed anomaly scan.
When do we do the detailed anomaly scan?
Between 18 and 20 weeks.
Correct. So that is 20 to 22.
Oh, okay.
So think again.
Yeah.
D.
Okay.
You
Yes,
had actually told D was correct.
Yes, ma'am.
Yeah.
But I forgot it. Okay, thank you, ma'am.
Yes. So when you actually came to D and you realized D was correct, you said D is correct. But what I would want to tell at that particular point is you should always finish reading all the options and then make a decision, because the next statement might be more correct than the previous one. Right? So always read all the options. Okay, let's move on to the next question.
Yes.
Yeah, this is an easy one. Who wants to attempt? You want to continue, or does somebody else want to do it?
Hello, ma'am.
You want to continue?
Oh, yeah, ma'am.
Yeah, go
34
ahead.
years old, had booking scan at 12-week scan, shows twin pregnancy with T sign. CRL is equivalent to 12 plus 5 for both twins. What would you document her plan of care? Aim of delivery for at 36 to 37 weeks. Cesarean section recommended mode of delivery. Serial scan every 4 weeks. Quad test screening at 16 weeks. I think A is correct, ma'am. Aim for delivery at 36 to 37 weeks. Because it is a
Yes, yes,
monochorionic diamnetic. Okay,
correct,
ma'am.
correct. Very nice
Thank
attempt. Thank you,
you.
Manikam.
Thank you, ma'am.
Yeah. Okay. So that was a good discussion about twins. So let me just briefly tell you how to prepare for Part 2 MRCOG. Initially, when I started off, I was really confused about how to go about it, what to do, what not to do, what to read, what not to read. And there is so much material available. But let me just tell you, you have to start with GTGs. And whenever there is a conflict between GTG or any other source, you always choose GTGs first. So the first priority is Green Top Guideline. Second is NICE, then TOG articles, and then the SIPs. Okay. So never just skip GTGs to sit and read TOG articles. I understand that in the recent few years, TOG articles have become important. And in the course, we will give a lot of attention to the TOG articles. But you should never ignore GTGs and NICE guidelines for the same. Okay. And there are some huge, really big guidelines, which whenever we see them, we are lost, where to start and where to end. These are the FSRH and DASH and MAPRACE and NHS CSP, which is so difficult for everybody. So all these, you just have to do the recommendations and we will guide you during the course about how to go about it. All right. And I just wanted to share with you all how I read and how it made the journey very easy for me. Med exam actually gave a schedule and I followed it religiously. Okay. And whenever you're reading a guideline, make sure to jot down the important point, make notes, and if possible, revise them the next day. Okay. And if you're very busy and you do not have time to make these notes, sit and write everything, what you could do is you could just print down the flow charts. Flow charts are very important. Like when you come to postmenopausal ovarian cyst, the GTG, in the end, there is a flow chart. So all the questions come from that particular flow chart. So you take a print out and you add down the important points to it. And keep solving question book simultaneously. So you have an idea about what kind of questions come in the exam and what they're actually looking for. If you aimlessly keep reading guidelines, you will not really know what to focus on and what to ignore. That perspective you will get when you solve question books. Okay. And whenever you find something new in the questions, just go back to that particular guideline, your notes, and add the points. Okay. And like I made a PPT for the incidences in this particular presentation. There are such incidences in all the guidelines, in all the topics. What helps is you make these incidences, make a separate book or a folder of these incidences and keep seeing them every now and then. It should pass below your eye, it should go below your eye, and then you will ultimately remember them. So once you do this, the first reading might take a lot of time and you might feel like, where is all this going in? I'll never be able to finish. But trust me, the second reading will take half the time. And when you're doing the third reading just before the exam, you just go through your notes, which will, a guideline will get over in like half an hour or 1 hour, or even lesser maybe. And then you see recall questions and strata questions, and then you keep going through your incidences. So by the end of this time, you will be thoroughly prepared. You will really be confident with yourself that, yes, I can do this. Okay. And about books, about what books to solve and how to solve these books and how to revise, we will be guiding you in our session about how to go about these. But I would just like to tell you superficially that whenever you're solving whatever questions whatever questions are going wrong, either just take a screenshot or just mark them and keep, so you revise them the next time. The ones that you know already, there is no point of revising them. Okay. And a lot of questions are old, and they follow old formulated guidelines, so that there's a lot of confusion. So what I would
Yes.
also, yeah. So
Hello, thank you so much, Pradnya. I really want to add one thing. I'm sorry to interrupt you in the middle of this
no
thing.
problem. No problem.
Because since we are talking about books, so I really want to emphasize on one thing. Okay, I'm sure like everybody knows me, but this is Dr. Jay Qureshi. Okay. So for the books, I want to tell all of you is that please start from the recent books. Okay. So in the recent years, we have had, very beautiful books. I really want to name from the Andrew Sizer to Justin Kunje to the Get Through books. Okay. These 3 or 4 books are very new books. So start your, the preparation if you want to solve the questions. So try, solving questions from these books and then go to the older books. From the old books for the EMQ part, Tahir Mahmood is such a brilliant book, I must say. Okay. It has got, the very, very beautiful scenarios, very beautiful questions to practice for, almost all of the questions. And then we have, the couple of, the other books as well. And for a single best answers, we have got many books, almost 10 books are there. So as many as questions you practice, so naturally it's going to help you in exam. Okay. And never take, like Pradnya said, that never take any book as your, the kind of a holy book that you will say that, okay, this is like, end of my life and I'm just going to read this book and I'm just going for this exam. No, you have to revise your keys as well, because some of the books have got, are formulated, from the old guidelines. So naturally, the keys are going to be from those guidelines. Yeah. So what you have to do is that, if you are, solving any of the question from any of the book, just be very vigilant with the keys. And if you are, well read, if you know that you have done something very nicely and in a very good way, then you will definitely come across that this is old guideline. And now I have to solve these questions in the line of new guidelines. Okay. And yes, this will come with the practice and this will come with the passage of time. And obviously, if you are with us in this journey, in this course, so obviously we will help you as well. Okay. Thank you. Thank you, Pradnya. And yes, it was a very brilliant session on multiple gestation. I really enjoyed.
Thank you, Dr. Zaid.
Thank you so
Thank you
much.
so
Okay. Carry on, sweetheart. Okay.
Thank you. Yeah. So I just want to tell you that we all have so little time, and we can't just sit and keep writing these exams. So our aim ultimately is help you to pass in one go, and this can happen with focused studies, with time management. And we are providing you a platform on Telegram, on Facebook to do discussion. Discussion helps a lot. When it comes to my exams, whatever I remember during my exam was whatever I had discussed. But this discussion has to be supervised by somebody. A lot of times students discuss and they just presume the wrong answer to be right at the end of the discussion. But it really has to be supervised by mentors. So, you do not blindly select anything in your exam, because that is a huge mistake. And you should never give up, really. Till the last question, you should not give up. And even if you get tired, maybe take rest, but don't ever give up, and you all will be able to do it. If I could do it, anybody can do it. So I just want to tell you all a little about us. Since the exam results have come out, part 1 results, part 2 results, messages have been pouring in, and it is so heartwarming to see all these messages from our batch students who've been saying thank you and who've cleared and who've got such amazing percentages. And it is all thanks to their hard work, and we were just as in the mentors are there just to guide. So for the Jan 2022 exam, me, Dr. Zaib, and Dr. Hassan are going to be there to help you in this journey. And we have specifically got 3 different plans for the course this time. There's Plan A, Plan B, and Plan C. So let me tell you all a little bit about each. In the Plan A, you will be getting GTG and the talk summary videos. You'll also be getting a mock exams, and you'll get GTG nice question banks along with talk question banks. In the Plan B, you will get everything that you got in Plan A, along with recorded video sessions along with study room for intense for discussion. And in Plan C, along with everything that I've already told you, there will be live sessions where we will have one-on-one interaction. And of course, we will be discussing a lot like students are already doing on the crash course group. So we'll be doing discussions, and there will be live sessions where you can ask questions and solve questions directly. Okay, so these are the 3 plans. If you have any doubts, you can always mail us on the given email ID, or call us on the number that is given here, or just drop in a message to me or Dr. Zaib or anybody from the backend team, and we'll always help you. As I've been getting a lot of requests since last few days since the result came out, I requested the management, and they have agreed to give a $200 off on Plan B and Plan C. You just have to use the GIFT 200 coupon just before you make the payment towards the end right here, and $200 will be deducted from your course fees. But this is valid only for 3 days. So I would really request you all, whoever wants to join, do it within 3 days to avail this offer. And if you all have any questions, I'm right here to answer. If you have any questions from the management, we are all here. So just let us know if you want to know anything.
And yes, I want to add one thing for the multiple gestation as well, that this is a very important guideline. You will have, a couple of questions in your exam as well. And those questions are going to be somehow very basic. And Pradnya has made a very good, the percentage, the slide. So definitely, you have to have all, the clear idea about this guideline, number one. Second question that, the most of the exam ask is that, the gestational age, when you will deliver in the different type of the multiple gestations. Okay, so it should be very clear in your mind for dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, monoamniotic, or whatever kind of multiple gestation it is. Okay, so at what gestational age you are going to deliver, this is very much important. Okay, so from multiple gestation, yes, then comes monitoring, then comes the the other questions regarding Down syndrome screening as well. Okay, this is very much important because in triplets it is changed, in multiple gestation it is changed, in dichorionic, in the monochorionic it is changed. Okay, so all you have to do is that study well and study hard for this guideline as well, and in fact for the all guidelines. Okay, and like Pradnya has said that we are here to facilitate you, we are here to help you. Then yes, reach out to us at any level, wherever you want to reach out to us, please do, to me, to Dr. Hassan, to Dr. Heather, to any of our team members. Okay, so we will try to facilitate you as much as possible. All right, thank you once again, Pradnya, for such beautiful session. It was marvelous. It was marvelous. Okay, thank you.
All right. So we have shared the link in the chat section. Whoever wants the link for the course, it's there in the chat section. If not, you can just message us on Facebook or wherever it's convenient for you, and we will definitely guide you. Thank you so much for giving me this opportunity. Thank you, MedExam. All right. Bye-bye, everybody.
Bye-bye.
Bye.